Yeah, now we can see your screen.
Okay, so I'm just gonna click it from the beginning. Okay, can you see it?
Yep, that's perfect.
Okay, all right. So thank you for inviting me to talk about survivorship care for lymphoma patients or survivors. So first I want to start by defining what cancer survivor is. An individual is considered a survivor from the time of diagnosis through the balance of life. And survivors include those living with cancer and those free of cancer. So I just want to show some statistics about cancer survivors in the United States. So as of January 2022, it is estimated or was estimated that there were 18.1 million cancer survivors in the United States. This represents about 5.4% of the population. The number of cancer survivors in the United States is projected to grow to 26 million by 2040. 26 million, that's a lot. This number is expected to grow as cancer survivors are living longer. In 2022, 70% of survivors in the United States have lived 5+ years since their diagnosis. Better diagnostic tools and more effective treatments are associated with increasing survival rates. Looking at the age distribution of the overall population of survivors, nearly about 80% of the survivors are aged 60 years and older. This is important to note as older adults have higher probability of other comorbid illnesses and clinical conditions that can compound the complication related to cancer survivors. Now, narrowing it down to lymphoma survivorship numbers, about 89,000 people in the United States are expected to be diagnosed with lymphoma in 2024. And just to break it down, 8,570 cases of Hodgkin's lymphoma and 80,620 cases for non-Hodgkin's lymphoma. In the United States, an estimated of 912,982 people are living with or in remission from lymphoma. About 165,856 people are living with or in remission from Hodgkin's lymphoma, and for non-Hodgkin's, about 750,000 people. The 5-year relative survival rate for lymphoma varies by type. Hodgkin's lymphoma, about 88.9%, chronic lymphocytic leukemia, about 87%, and for non-Hodgkin's lymphoma, about 73%. And these are statistics from American Cancer Society. So survivorship care. So the concept of survivorship care actually started way back in 1980s, but it's not until early 2000 that the Institute of Medicine report from a big survey that was done from thousands of cancer survivors. It was published in 2005, and it was from cancer patient to cancer survivor lost in transition. The survey revealed that most patients were not doing well after treatment. This increased the awareness that coordinated follow-up care can enhance the overall health and quality of life for cancer survivors. And I will discuss what challenges the survivors mentioned in the survey in the next slide. The good thing about the report is that since that report was published, there were notable advances have been made in the care of survivors, such as development of clinical guidelines, like algorithms, emergence of survivorship care plans, progress in health policy initiatives, and increase in clinical education for healthcare providers. So from the survey, these were some of the challenges that the patients mentioned, that they have persistent symptoms even after cancer treatment, health effects, new onset years after treatment, emotional symptoms, loss of relationships and economic distress were mentioned, difficulty finding physicians after cancer treatment, and lack of communication among physicians. The last one is still a problem today, and it's very important, and I will discuss that later on. So when at MD Anderson, we tried to introduce the concept of survivorship care early on, and throughout their treatment phase. Even then, once the patients are ready to be transitioned, they still have concerns, and these are some of the concerns that we have encountered in our clinic. Patients often ask, now what? What do I do now that I am no longer on treatment? Patients are so used to coming to the clinic once a week, twice a week, once a month, every 3 months. And now they're being told that they only need to come once a year. And this kind of gives them anxiety. So it's kind of like a separation anxiety from their oncologist. They're concerned that if they're not having CAT scans, how will they know if their lymphoma is back? They have questions about how often they should come back to see their oncologist. They want to keep getting scans, and they want to see the same doctor every time they come. Then they want to know if the survivorship team will take care of all their chronic illnesses and other issues, and how often should they be seen in survivorship clinic, and what if they have late effects of their treatment, who do they call or contact? So these are just some of the concerns that the survivors voice when they're transitioned to survivorship. So there are 3 phases of cancer survivorship. There's the acute, which begins with diagnosis of cancer and includes the period of testing and treatment of cancer. Extended or intermediate begins upon reaching remission and concluding the acute treatment. This phase can include maintenance, consolidation, or watchful monitoring. And the permanent or long-term, depending on the disease type. This is the phase of low risk of recurrence, equated with quote-unquote cure in many cases. So what is cancer survivorship care? So cancer survivorship care focuses on the health of people who have been diagnosed with cancer, from diagnosis through treatment and beyond. Includes physical, mental, emotional, social, and financial effects. Survivorship care includes monitoring of late effects, providing risk reduction, and offering support. Cancer survivors may experience physical issues, fatigue, cognitive dysfunction, and emotional distress. There are key domains of survivorship care. Number 1, cancer surveillance and screening for late relapse or subsequent malignancies. Risk reduction by lifestyle changes and cancer prevention. Late effects, side effects monitoring and management. Psychosocial support services, and management of comorbid illnesses. So I just want to share to you about our lymphoma survivorship clinic. So our survivorship clinic is a program where patients initially treated at the lymphoma center or new patients and have been cancer-free for specific years come in once a year to be seen by an advanced practice provider with tests like chest x-rays, mammograms, blood work, just to mention a few. These yearly visits allow providers to keep an eye on patients' labs and scans to ensure we do not miss the signs of secondary cancers, but also offer a wide range of supportive care for late effects of treatment to patients and their loved ones. So our survivorship clinic is run by advanced practice providers, mainly nurse practitioners and physician assistants. We do have a supervisor or medical director, which is a lymphoma doctor. We have nurses, medical assistants, and patient service coordinators who are in charge of scheduling. Our survivorship clinic in MD Anderson for lymphoma started in 2012. In 2012, we only had like 58 patients. but the following year it all like tripled. And you can see every year we were growing, except in 2020, as we know what happened in 2020, we had COVID or the pandemic. So we had to stay for like 3 months. But once we reopened the following year, our numbers keep growing every year. We do follow guidelines, or we do have algorithms for our lymphoma survivorship clinic. We have algorithms for the 4 types of the lymphoma. We have one for Hodgkin's lymphoma, indolent lymphomas, which are the follicular lymphomas or the slow-growing ones. Aggressive lymphomas include diffuse large cell, Burkitt's lymphoma, and recently we included mantle cell lymphomas too. And we have algorithm for T-cell lymphoma. Patients can be referred to lymphoma clinic anytime. They can be co-managed, meaning being followed by the oncologist and the survivorship team, or they can be fully transitioned, meaning survivorship team will take over the care of the patient. This is an example of the algorithms that we follow for Hodgkin's lymphoma. You can see on the left-hand side, they usually get transitioned to survivorship after 2 years post-treatment, and they have no evidence of disease. The algorithm includes the key domains of survivorship care: the surveillance, monitoring for late effects, risk reduction, early detection, and psychosocial functioning. And this is the second phase of the algorithm. Okay. So survivorship providers, we follow the algorithms. Oops, did I lost you guys? Sorry. So we follow the algorithms, surveillance for late response symptoms, secondary malignancies. We monitor for late effects, and we refer to appropriate consultants. Example, cardiology consults. For our lymphoma patients, we do refer a lot to cardiology because of their exposure to the chemotherapies that we give and in the chest. We yearly review cancer prevention and screening indications, documentation of screening, appropriate referrals, referrals to smoking cessation, skin cancer screening, colonoscopy histories, also engagement of patients focused to future lifestyle to maintain health, and referral for supportive care such as dietary consults, integrative medicine, weight loss counseling, etc. We also document patient-reported outcome surveys. We document cancer screening events and other maintenance such as vaccinations. There is a survey that we send out to patients a week before they come for their visit. It's called patient-reported outcomes, or we call it symptom survey. And we send them out and have the patients fill them out. And we do get high alert if they give us a score of 8 or higher. So it's just a way of us keeping track of their symptoms and also making us act proactively. So in that way, if they're having symptoms when they come in, we already have a plan for them. Yearly update to primary general medical providers. We have been emphasizing this a lot. We encourage our patients to have a primary care provider, and we tell them that we are not their primary care provider because we only see survivorship patients once a year. So it's important that we do have a primary care provider. In our clinic, we do provide our patients a survivorship care plan. This survivorship care plan includes the cancer stage or grade of their lymphoma. It includes the date of their initiation of their chemo or treatment and the completion of treatment. It also includes the list of treatments such as surgery, chemotherapies, radiation, hormonal therapies, immunotherapies, results of any diagnostic tests, psychosocial, nutritional, supportive services provided, and also include the contact information of our clinic and the hospital, and the survivorship care plan is provided to patients upon completion of their treatment. This is an example of the treatment summary that we provide to patients when they come in. I like to emphasize to the patients the treatment that they have received and what they are at risk for. For example, in this patient, she received mini RCHOP. And for the acronyms, I like to spell it out because I tell patients to provide a copy of this and give it to their primary care provider. Most community hospitals, physicians, doctors, may not be familiar with what's included in RCHOP. So I like to spell them out in that way. They would know what chemos were included in RCHOP. And for this patient, I tell her or him, hey, this is what you got, and this is what you're at risk for. Like the patient was exposed to adriamycin, which can cause long-term effect on their heart. So I emphasize that you need to get an echocardiogram, or you need to see a cardiologist if you have this, and that. So whenever I present this to patients, they're actually very receptive of being seen in survivorship because they appreciate it. And most of the time, their oncologists have no time to explain this to them. And also, even though they did sign the consent form way back before they started treatment, they probably already forgot this information. This patient also received radiation therapy, so I emphasize to the patient that you had received radiation to your pelvis, you're going to be at risk for bone health issues, so you need to get bone density done, and things like that. And this is an example of the passport or part of the care plan also, and it documents when the patient last had the test performed, and also the future date on when the test will be performed. So it gives us keep track of the patient's test when it's due, like for colonoscopy. It was, for instance, if it was done today, and if it's every 5 years, then the next one will be in 2031. So patients appreciate this if we give it to them. Moving on to monitoring for late effects of the treatment, cardiovascular risk. As I mentioned earlier, a lot of our patients receive chemotherapy and some radiation therapy, and if they have received radiation to the chest area, they're at high risk for cardiovascular risk. So I tell patients you need to have your echocardiogram done or your EKG. Normally, recommendation is for patients to get an echocardiogram at least 6 to 12 months post chemo, and every 5 years, depending on the result. If they have other risk factors like hypertension, diabetes, I would recommend that you see a cardiologist or be followed by cardiologists. I emphasize control of blood pressure, cholesterol, weight management, eating heart-healthy diet, physical activity or exercise. Breast cancer risk is another big one, especially for female patients who had received radiation to the chest, or mediastinum or the axillary area. For patients who receive radiation at the age of less than 30 years old, recommendations for them to get mammogram and MRI alternating every year because they're high risk for breast cancer. And for adults, annual mammogram beginning 8 to 10 years post-radiation or at age 40, whichever comes first. Lung fibrosis or scarring is common also for patients who have received bleomycin or radiation to the chest. We do annual chest X-ray, and if they have pulmonary symptoms or lung symptoms, I would recommend that they see a pulmonologist. Skin cancer is another risk because of radiation exposure, and just having history of cancer puts them at high risk for secondary malignancy. So we recommend our patients to get annual skin cancer screening by a dermatologist. Carotid stenosis is another risk Sometimes oncologists forget to recommend their patients to get carotid stenosis, especially if they receive radiation to the neck area. And they should get it by you should get the carotid ultrasound at least 5 or 10 years post radiation. Thyroid abnormalities during chemotherapies and radiation to the neck can cause thyroid abnormalities, especially hypothyroidism. We recommend our patients to get their thyroid function test annually. Benign leukemia or myelodysplastic syndrome is a potential late effects of chemo, especially alkylating agents such as cytoxin, cisplatin, melphalan. That's why when patients come to us on their annual visit, we all blood work always includes CBC or complete blood counts, which include white blood cells, hemoglobin, and platelet counts. Early menopause is another late effect of treatment. Early menopause can lead to bone health issues like osteopenia, osteoporosis, chemotherapy, and radiation to the pelvis or hip area can lead to bone health issues. Sexual dysfunction, I tell my patients to discuss this with their PCP, be open about it. They can be referred to GU or GYN or even counseling, depending on what the cause is. Fatigue is common, could be due to comorbidities, abnormal labs like anemia, low vitamin levels, hormone abnormalities, thyroid dysfunction, or sometimes it's just from stress or lack of sleep. Infection is another risk because patients still get persistent low white blood cell count even after chemo, that their blood counts never get back to the normal level. Low immunoglobulins put them at risk for infection. As for cancer detection and prevention, we tell patients it's important to control their or maintain their weight or weight loss. I don't know if you guys know that obesity is linked to about 13 types of cancer. Postmenopausal breast cancer, colorectal cancer, kidney, endometrial cancer, thyroid cancer, pancreatic, multiple myeloma, liver cancer, ovarian cancer, adenocarcinoma, the esophagus, upper stomach cancer, gallbladder cancer, and meningioma. We emphasize patients do not smoke or use tobacco. Protect yourself from ultraviolet rays. Wear your sunscreen, SPF 30 or higher when out in the sun, or wear a hat or long sleeve shirt. We emphasize about vaccines, especially those patients who had splenectomy or stem cell transplant. Limit alcohol. Again, get screened, get your mammogram done, PSA level, pap smear or well woman exam, colonoscopy, skin cancer screening, lung cancer screening for smoker or ex-smoker. And we also talk about genetic counseling for patients who have family history of cancers. Psychosocial well-being and mental health. We also focus this on patients when they come to their annual visit. We always emphasize about maintaining healthy sleep habits. Getting enough sleep is important for your overall health and well-being. Most adults should aim for 7 to 8 hours of sleep each night. Prioritize self-care. Make time for activities that bring you joy and relaxation, such as exercise, meditation, hobbies. I tell my patients, go on vacation, go get your nails done, just get out of the house, do something, connect with others. Strong social connections are important for mental health. I tell my patients to try to maintain relationship with friends and family and seek out new social connections if needed. Get professional help if needed. If you notice signs of distress, such as prolonged sadness, anxiety, or difficulty functioning, do not hesitate to get professional help from a therapist or counselor. Practice mindfulness. Mindfulness techniques such as deep breathing exercise can help reduce stress and anxiety. I tell patients to go do yoga or go walk in the park, things like that, something that will get them out of the house. But financial toxicity is always a concern after cancer treatment because of unpaid medical bills, credit card debt, mortgage, loss of income, lack of employment, lack of insurance. I usually refer them to social worker to see if there's any kind of financial assistance that they can be eligible for. There's some discount prescriptions out there, like Drug RX offers discount, and some pharmaceutical companies have their own discount coupons. I tell patients to check their local organizations, foundations, health fairs, especially health fairs. Sometimes they offer discount services or free services like skin cancer screening. Some offer free mammograms. Disabilities, patients still have disabilities even after treatment because of the cancer itself or from the treatments that they have received. Chronic pain is still very common, neuropathy. I usually refer them to pain clinic or give them prescription for PT or OT. At MD Anderson, we have integrated medicine that we can refer them to for acupunctures and things like that. We help them fill out their family medical leave of absence form. If they need handicap placard, we give them prescription for it, or they can get it from their primary care provider or oncologist. Body image is still a concern, especially with young adults. Relationship issues, I usually send them for counseling. So why do I need survivorship care? I just want to share this letter that I received several years ago from a family member of a patient, young patient who had Hodgkin's lymphoma. Just to summarize, her sister was diagnosed with Hodgkin's lymphoma at 16 years old. She was treated with radiation I assume it was to the major spinal chest area, and chemotherapy. So she did very well. And after several years, she was discharged to her primary care physician. And according to the sister who wrote this letter, her sister who had the Hodgkin's disease was never given information about what she is at risk for and what to look for and what type of or what kind of screenings that she should be doing for receiving radiation to the chest or receiving chemo. So the sister developed thyroid issues and also noticed she had a lump on her breast, and it took them a while to get a mammogram. She finally had a mammogram done, and sure enough, the lump was there, and biopsy, it did confirm breast cancer. So the main thing was the sister never was advised to get annual mammogram or alternating MRI of the breast due to history of radiation. So the patient did receive chemotherapy for her breast cancer, but she died for some reason abruptly. She died very quick, and the sister mentioned that if she would have been given adequate care or information, the breast cancer should have been detected earlier, and maybe the sister would still be alive. So I hang on to this letter because I think it's what got me or lead me to survivorship clinic or caring for survivors. So the main takeaways is if you're being transitioned to survivorship, you can always ask questions. Don't be afraid. Some of our patients don't want to be transitioned to survivorship, which is okay. Inquire if your cancer clinic has a survivorship program and ask for referral. know the late effects from treatment and what you are at risk for. You should ask for a copy of your treatment summary if your clinic or hospital have a treatment summary for their survivorship clinic. And you should keep a copy for yourself and one for your primary care provider. And you should provide your oncologist the contact number of your primary care physicians. In that way, they can communicate. And I always tell my patients to provide me updated information about their primary care provider. And always offer them, should I send some information to your primary care providers? And they're always receptive on that. I tell my patients, know what available resources are out there. Your local foundations, national organizations, they have a lot of information about survivorship care. Especially American Cancer Society, the Leukemia and Lymphoma Society, they have a lot of information regarding survivorship care. And I believe this is all I have. So any questions?
Thank you so much for that wonderful presentation, Dr. Mullen. So yeah, it's now time for the discussion part of today's webinar. So if you have any questions about today's topic, now is your chance to ask. And as a reminder, you can ask a question or make a comment by using the chat icon on Zoom. And our first question is, how can we safely rebuild strength and stamina after treatment?
Yeah, so it all depends on what's causing your symptoms. Like I tell my patients to get their thyroid function checked. Even having low vitamin D causes low energy level. I like to engage them in exercises, even walking, light walking, get plenty of sleep, and things like that. So it all depends on what's causing the fatigue or the low stamina.
Thank you for that answer. And then that kind of goes with our next question, which is, can I expect that my energy levels will eventually increase after treatment, or should I expect them to always stay this low?
Again, it all depends on what's causing the low stamina. Usually, most of the time, it should improve the farther you are away from the treatment. So if it's not improving, I would recommend, checking your hormones, again, your blood work. Sometimes patients come to the clinic and we roll out everything except sleep apnea. So that could be causing the patients to have low stamina because they're not getting that deep sleep that they need at night. And I have had several patients that I refer them to get checked for sleep apnea, and sure enough, they do have sleep apnea, and then they come back the following year and they're like thankful, like, thank you for telling me about getting checked out for sleep apnea. Now I have more energy, and so always get checked for other reasons. If it's not improving, there might be something else that's going on.
Perfect. Thank you. And then the next question is, are there any diet or supplement recommendations that you give to survivors?
There's really nothing. I just tell them to eat regular diet and be mindful about controlling the blood pressure, cholesterol. If you're trying to build up your muscles after treatment, because with chemo you may have lost your muscle mass. So high protein diet might help. staying active gonna help, and drink plenty of water. That's about it. Some of our patients have a hard time gaining their weight back, so I refer them to our dietitian and have them count their calories, or sometimes they may still not have their appetite, so they may benefit from appetite stimulant. But I tell my patients, if they have lost a lot of weight during their treatment, and they're just trying to build up, I just tell them just eat healthy, be mindful of your, if they're diabetic, watch your, sugar. If you're trying to build up muscles, add more protein. And I usually refer them to dietitians.
Perfect. Thank you. Our next question is, how do you explain survivorship fears to friends and family members who think you should be back to normal immediately after treatment?
So what I usually tell the patients is it's not gonna, they're not gonna, because they want everything back to normal right away. So it's gonna take time. It's gonna take weeks, sometimes even months, sometimes even a year. What was the second part of the question?
How to explain that to friends and family members so they understand.
Oh, okay. So friends and family members.
Yep.
Yeah. So I'll just explain to them that they have to be patient. The survivor is not gonna be back to his or her normal self right away. It will take time, and they can provide support by maybe like going to the gym with the survivors, taking them out. If they're seeing that the patient has anxiety or depression, they can help with that by talking to them, just being there as support. Like I said, it's gonna take time. I have had patients that still not back to their usual self, even a year after treatment. And always ask them, what do you think is wrong with you? How can we help? It's just a lot of encouragement from the family member and support. And if still shows no improvement, I probably would refer them to counseling. And again, it all depends on what their symptoms are. It's important to find out what could be holding them back from getting back to normal.
Yeah, absolutely. That's great advice. Thank you. Our next question is, what are some signs that my anxiety may need professional support rather than just managing it on my own?
So if it's interfering with their work, with their self-care, with their activities of daily living, that's a sign that they need help. I actually just had a patient last week who called and was begging me to refer him for counseling because he could not function at work anymore. And he is about to lose his job if he doesn't get help. He went to his primary care provider and he was given excuse for intermittent leave. In that way, he can go to his appointments or get some counseling. So if it starts interfering with your activities of daily living, your daily functions, you cannot focus at work, or you're having difficulty with your relationship with other people, it's time to get help. And we're lucky at MD Anderson because we have places where we can refer them. We have integrative medicine, we have supportive care, we have psych unit, psych department. So, yeah.
Thank you. And that story you just shared goes into our next question, actually, which is, are there protections or accommodations that cancer survivors can ask for at work?
Uh, yeah, it depends on what they're looking for or what kind of protection they're looking for. If it's like I mentioned earlier about family medical leave, if they're experiencing, still late effects from their chemo or from their treatment, and they're not able to, carry their workload. For example, like we have patients that work at warehouses and they're not able to lift anything heavy. They can actually get a, letter from their primary care provider saying that they should not be lifting anything heavier than 20 pounds or something like that. Yeah, it all depends on what they need. So there should be some protection, like disabilities and things like that.
Perfect. Thank you. And then our next question is, are lymphoma survivors considered immunocompromised long-term following treatment?
Not always, no. Only the ones that are like have persistent cytopenia, meaning low blood counts, especially low white blood cell counts, or low immunoglobulins, yes, you are still considered immunocompromised. But if your counts have been normal, you should be fine.
Thank you. And then it looks like the last question we have for right now is there research or advancements being made in the survivorship space to hopefully make things better for survivors in the future?
There's a lot of studies, research going on right now. I don't. I guess it has to be more specific. What the question is, like in what area of survivorship?
Um, that's all the question says, just in the survivorship space, but I think it's definitely reassuring to know that there is a lot of studies
Oh
being
yeah,
placed.
there's a lot cardiovascular studies um, at MD Anderson. Actually have just learned that we have an ongoing study in our radiation department about muscle fibrosis or muscle stiffness for patients who had received radiation. So, which is one of the side effects, late effects of radiation is muscle stiffness or muscle atrophy. So I just learned actually that there's an ongoing studies on that about improving your muscle function after radiation. So there's a lot of studies, research out there, but yeah, it has to be specific. I don't know exactly what the question is, like specific research.
Yeah, well, that sounds like a great study happening at MD Anderson and definitely reassuring and exciting to know that there is even more research being done regarding all different aspects of survivorship. Um, but that was the end of our questions. So thank you so much again, Dr. Mullen, for your presentation and for answering all these questions for us.
Sure.
Really quick before we go, I wanted to highlight a couple of upcoming events that we have. So this Thursday, we have an event for non-Hodgkin lymphoma patients. It's a community gather. Next Tuesday, May 26th, we have a webinar about palliative care and how it fits in your treatment plan. And then on June 18th, we have a webinar about when eating is unpredictable, nutrition tips for parents of children with cancer. We also have a number of upcoming in-person events that I want to highlight. Connect to Cures is an opportunity for you to connect with other blood cancer patients, learn from healthcare experts, and discover resources in your community. The dates and locations are here on the screen, and you can scan the QR code in the corner to learn more and register for any of these upcoming events. And a huge thank you to all of you for being part of our HealthTree community. Your support means so much, and we're so grateful to have you here. I've included my email on this slide, so please don't hesitate to reach out if you have any questions. And I look forward to seeing you all at another webinar soon.